Dr. Arup, you can start.
Okay, so a very good morning, friends, and a warm welcome to the first glaucoma session of the BOA MOS Summit. And I am really grateful to the organizing committee for giving me an opportunity to chair this session. And we have a series of interesting talks lined up. And I think though one or two speakers may not be there, but still I think we can compensate by having a very vibrant discussion session if we have any time left at the end of the entire, all the didactic lectures. And with these introductory comments, I think we'll get going and request the first speaker to come on board. Gonioscopy, Dr. Sunil.
Yes, sir. I'll share my screen.
So Dr. Sunil Jain needs no introduction. He is a very scientific and mathematic in his academic. He is a gem of a person. He has so many presentations on his names, so many publications. We have heard a lot of time to him in conferences, and he is always eager to answer all the questions on the dais and off the dais also. So it gives me pleasure to introduce Dr. Sunil Jain, sir.
Yeah, good morning, everybody. Can you hear me, sir? Can you see my screen?
Yes, yes, sir.
Okay. Thank you, the organizers, the BOA, and the scientific committee for having me at this session. With the permission of the chair, I'll be talking on gonioscopy. So the importance of gonioscopy, it is always essential because almost 50% of population of glaucoma are angle closure glaucomas. And unless you do gonioscopy, you won't be able to detect angle closure glaucomas. Once a gonioscopy is put over the patient's eye, the best part is not only you can see the site of impedance of the aqueous outflow, but also whether any additional mechanisms are responsible for the glaucoma can also be seen clearly. The important part which I would like to convey, it has to be repeated periodically to detect any additional mechanisms which might come forth in later part of the patient's life. So two types of gonioscopy. There's a direct gonioscopy and the indirect gonioscopy. These are the direct gonioscopy lenses. The advantage is that you get a straight on natural view of the angle, and it allows the comparison of both eyes simultaneously. The disadvantage is it has to be performed only in supine position. Hence, its practicality, it is used only during pediatric glaucoma surgery or the newer angle surgeries. This is the view which one gets using a direct gonioscope of the angle structures. The indirect gonioscopy, which normally all of us use in the OPD, the advantage is it gives the additional advantage of the slit lamp that you can magnify the image, you can have a controlled illumination, and hence it's more convenient. There are two types of lenses in these. The one which need coupling agents, these are the normal Goldman lenses. The one which do not need a coupling agents, these are the 4-mirror lenses. And this is how you would insert a gonioscopy after putting topical proparacaine in the eye of the patient and examine the angle structures. Now, the routine lens, what everybody uses is a single mirror or a 3-mirror Goldman lens. The advantage, because of the suction effect, you are much more in a comfortable position examining the eye, especially for the first-time users. That's the ideal way to start learning gonioscopy. The lens is very well centered, and you can comfortably examine each structure. Also, it can be useful in the laser procedures when you have to do an SLT for these patients. The disadvantage is many times because of scleral indentation, it might distort the anatomy of the angle structures. Now, this is the image what you will see. The image is not an inverted image. It's the reverse image what you see. So if you are looking for the inferior angle, you will look into the superior mirror. And this is the structure. 6 o'clock will appear as this. The nasal structure will appear on the nasal side, and the temporal structures will appear on the temporal side. And as you rotate, this relation is maintained. Coming to 4-mirror lens, I think it has a big advantage that no need for any coupling agent. Plus, you can do what is known as dynamic gonioscopy, which I'll demonstrate to you. The disadvantage is there's a certain learning curve because certain excess pressure might cause corneal folds, and then the visualization gets obscured. And these are the different 4-mirror lenses. This is the difference between a 3-mirror lens and a 4-mirror lens. So how do you start about learning gonioscopy? Obviously with the help of an experienced examiner. So you need to know what the normal structures are before you detect what is abnormal. So I'll take you through a lot of gonio photographs to help you know what gonio, the angle structures look like in different conditions. This is how a normal wide open angle would appear to us. And to start off with the structures, we tend to grade them from the cornea towards the iris. So the first structure you would look at is the Schwalbe's line, followed by the pigmented trabecular meshwork, then the scleral spur, and the ciliary body band. Now, once you have put the gonioscopy, you need to answer certain questions. So first, is the angle occludable? So that's how you would differentiate whether the patient has an open angle or a closed angle. After that, the next thing, are there any additional abnormalities in the angle? And also you need to look at the curvature and the incision of the peripheral iris. Now, there are certain lighting conditions which you will have to follow to answer the first question, that is whether the angle is open or closed. Dim the room lights. Patient has to look straight ahead. And the slit beam should be a very small beam. It should not be crossing the pupil so that it can, otherwise it can cause an artificial constriction of the pupil, and then closed angle might appear as an open angle. Now, once the slit beam is basically focused into the angle structures, the slit beam gets divided into the epithelial beam and the endothelial beam, which come to a focus at Schwalbe's line. This is where the Descemet membranes ends. And this is the first structure which needs to be identified, because after that, what structures you see, that will help in grading of the angle. So this is known as the corneal wedge test. Once you have diagnosed the patient to have an open angle or closed angle, and if the patient has a closed angle, you would like to do an indentation gonioscopy. That by pressing the central cornea, the aqueous gets pushed into the peripheral angles and the entire lens iris diaphragm goes backwards. So if it's an apposition angle closure, the angles will open wide open and you won't see any goniosynechiae. But if it's a synechial angle closure, you'll see goniosynechiae, which I'll show you in my gonio photographs. Once you determine whether angle is open or closed, you increase the illumination, let the pupil constrict, and try to look for any additional features like pseudo-exfoliation, neovascularization, which would be present in the angles. In addition, you look at the peripheral iris curvature. So a convex iris curvature usually seen in angle closures. A concave iris curvatures usually seen in aphakic glaucomas, pigmentary glaucomas. If the peripheral iris is inserted more anteriorly, this condition usually seen in juvenile open angle glaucomas. So apart from diagnostic, it has certain therapeutic applications also, and hence you need to learn your gonioscopy very well. Let's go to certain clinical examination. This is what a normal wide open angle would look like. Now this is an angle closure. When you initially see, you might feel it's an open angle because of the pigmentation, what you see here. And you might think this is a trabecular meshwork. This is actually pigmentation over the Schwalbe's line. So it's only when you do indentation, okay, the entire lens diaphragm, iris diaphragm goes backwards, and you can see the trabecular meshwork lying here, and you'll see these goniosynechiae. So this is how you could have missed a closed angle, and the treatment would have changed. This is when it's completely zippered up, a complete synechial angle closure. In spite of indentation, the angle does not open. After you've done a YAG arrhythmia, you can detect what is known as the Plateau Iris, and where you see the sine wave sign. This is the peripheral convexity due to the anteriorly rotated ciliary processes. Then there's a dip at the equator, and then again the next convexity of the lens equator. This is how an angle structure would appear in a anterior iris incision, a posterior embryotoxin, an Exenfield anomaly. This is how a pathological synechiae would appear, where there will be peripheral tenting of the iris, and basically the iris gets pulled up, as compared to iris processes, which are very fine fibrils, which go along the concavity of the angle. We will also see neovascularization, the arborization of the new blood vessels all over the trabecular meshwork, causing neovascular glaucoma. This is how in the olden days, when the incision would be badly sutured, you would have a fibrovascular ingrowth. You can also have a malignant glaucoma present in the angle. On gonioscopy, you can detect a localized mass out there. This is how a pigmentary glaucoma would appear. You can see dense pigmentation of the trabecular meshwork along with Sampola-C's line. In pseudo-exfoliation, you see these flaky materials lying in the angle. Post complicated cataract surgery, you can see vitreous lying into the anterior chamber, along with the extensive pigment dispersion causing secondary glaucoma. These are older generation anterior chamber lenses, which would cause severe inflammation and complete synechial angle closure. Sometimes epinucleus piece is left behind in the angle after a phaco, and this tends to cause intermittent spikes of intraocular pressure and uveitis. In a post-traumatic, you will see sphincter tears in the pupil along with an angle recession, sometimes a foreign body in the angle. And these are inflammatory goniosynoviae, and as you can see, the angle is wide open. So this is to differentiate between a goniosynoviae due to angle closure, where you have occludable angle, whereas here you'll have a wide open angle all over, along with intermittent goniosynoviae. You could have silicone oil bubbles in the angle. Post-trabeculectomy also, a gonioscopy helps you, especially post-operatively if you see a sudden peaking of the pupil. And when you insert a gonioscopy, you'll realize that the peripheral iris is gone and occluded your internal ostium. And that's how the failure of a trabeculectomy could happen. Rarely you can see vitreous coming and obstructing the internal ostium. And coming to therapeutic applications, well, the gonioscopy can be used for ALT or SLT. Sometimes in a patient of traumatic aniridia, you can have a direct cyclophotocoagulation of the ciliary processes. Coming to non-glaucomatous conditions, the ciliary body mass I've already explained to you. This is a patient who came to us with a bleb, and there was no history of any glaucoma in the patient. And it's only when you did a gonioscopy, you saw a fish mouthing of the small incision cataract surgery which was done. So all this required was basically a suturing of this wound, and the bleb disappeared. So gonioscopy is mandatory in a patient for diagnosis and management of glaucoma. Also in the post-trabeculectomy period to evaluate the internal ostium, and even in certain non-glaucomatous conditions like ciliary masses and inadvertent blebs. Thank you.
Thank you, Dr. Sunil sir, for your nice presentation and very beautiful photographs. Gonioscopy is a basic to start for the glaucoma. So thank you very much, sir. So I request our next faculty, Dr. Nitin Deshpande, to talk on dry eye in glaucoma.
Yeah. Is my screen visible?
Yes, yes, sir.
Yeah. Good morning, everyone. Thanks for inviting me for this talk. And I'm going to talk about a very important issue of ocular surface disorder in glaucoma patients. Hollow et al. Described it as an imbalance of ocular surface homeostasis caused by the toxic effect of chronic topical medication, which leads to tear film instability, epithelial damage, and inflammation. We know that the old age issues like glaucoma, ocular surface disorders, they coexist. And once they coexist, it creates more issues, like simple issues like doing a IL-power calculation for these people with cataract, or adding medications for glaucoma as well as ocular surface, because we know that more than 2 drops are going to create serious compliance issues in these patients. So it is very difficult to manage coexisting disorders. The drops we generally use have preservatives like BAK, which is bacteriostatic bactericidal. However, a chemical like a BAK doesn't differentiate between a cell membrane of a bacteria or our own cell walls. So it damages both at the same time. So that's why we have new preservative-free drops, which either become hydrogen peroxide once we instill it and then just becomes a water, or they just break into the normal tear film electrolytes once we instill them. So that is the way to go, because that reduces ocular surface disorder in these patients. We know that BAC it causes harmful effects on the ocular surface, and it is time and dose dependent. A small single drop, 1 drop with some amount of BAK still is okay, but when people like glaucoma who use more than 2 drops, there is an additive effect of this BAK on the ocular surface causing more harm. Now, what is the impact on the quality of life? Now, this study said that increased number of drops caused increased percentage of dry eye symptoms, and there is a decreased emotional well-being in these patients. So it really has a lot of impact on patients' quality of life also, which is a very important issue. Now, ocular surface disorder can present in different forms like SPKs or just a tear film instability or allergic reactions, pseudopemphigoid, frank dry eye, or vortex keratopathy with newer drugs like netaracidil. So we have to be vigilant to look for these signs when we check every patient of glaucoma. This was a test called Essentiometry done, and they found that both corneal and conjunctival sensitivities were reduced in patients using hypotensive drops, and it was more affected in people using timolol, that is beta blockers. Why this is important is these patients don't come and complain to you that they have dry eye symptoms. You have to look for them yourself. And there is always this difference in signs and symptoms. So every glaucoma patient that walks into my clinic, I make sure at least I do a Shermer's for them to detect dry eye. We know goblet cells are important, and we know that goblet cell density is also important for our surgical outcomes of trabeculectomy. But these ganglion cells are damaged because of topical anti-glaucoma drops, and we know that prostaglandin analogs are the best when it's about sparing these conjunctival ganglion cells. This was another study for inflammatory mechanism where glaucoma drops were instilled only in one eye and other eye served as a control. And it was found that the treated eyes had poor tear breakup time, had a higher osmolality, had more hyperemia, had more eyelid margin abnormalities, had poorer tear meniscus. And you can see the electron microscopy photo in these patients where there is a loss of goblet cells and there are cystic changes in the conjunctival epithelium in patients using topical glaucoma drops. Now, again, meibomian glands are also badly affected. We know that the treated eyes, this study says that the treated eyes had higher scores of lid margin abnormality. Their meibo scores were higher. The more the damaged meibomian glands, higher is the meibo score. And you can see in the photos on the right side, there are even gradually more loss of meibomian glands. We know that significant higher meibo scores in eyes treated with prostaglandins and beta blockers. So prostaglandins and beta blockers are more toxic to meibomian glands. So people using these drops, you have to be more vigilant. There was another paper about this cellular toxicity, and it compared toxicity among different drops, BAK and BAK free. It was found that the surface toxicity was proportional to the amount of BAK that was present in these different drops, and the newer drops with preservatives like Sofzia and Polyquad were far more gentle on the ocular surface compared to the drops which had BAK as a preservative. Again, comparing different prostaglandins, travoprost was found to be the most gentle one on the ocular surface with lowest OSDI score. Higher the score, more is the ocular surface damage. Lower the score, better is the ocular surface. This was a small study conducted by us where we wanted to assess surface characteristics, inflammation, and dry eye symptoms in patients using glaucoma medications. We took patients that were using at least drops for at least 3 months, and we did plethora of tests on these patients to evaluate their ocular surface. We also did OSDI questionnaire, and glaucoma patients had tolerance to medication questionnaire. Now, Inflammadry is done with this simple kit, and it is very helpful. We find large number of glaucoma patients have a positive Inflammadry test, and treatments like Lipiflow help a lot or in reducing surface inflammation, along with drops like cyclosporins and mild steroids where inflammation is high. The meibomian gland score was done with a Sirius, or we also use Lipiview to do that. Then this is a very interesting finding of lid viper epitheliopathy. Now, the lid viper zone is between the mucocutaneous junction and a subtarsal fold, and when it moves on the surface, there is a staining. We use Lisamin green to stain this area, and this is the grading. And I'll just go ahead. These are the biostatistics that we use to analyze our data. We found that inflammatory, although MMP9 was equally positive in both groups, we found that positive results were associated more with dryness, increased corneal staining, and higher lid viper epitheliopathy. Then meibomian gland loss was higher in glaucoma subgroup. Tear breakup time was, although not statistically significant, but was more worse in glaucoma subgroup. corneal staining was found to be more in glaucoma, while conjunctival staining was found more in non-glaucoma group. Schirmer's was definitely worse in glaucoma subgroup. Lid Viper epitheliopathy, the staining was higher in upper lid and both lower lid in glaucoma groups compared to the non-glaucoma group. And OSDI scores were, although they look almost similar, but again, the issue was, as I pointed out in the previous slide, that their ocular surface is sometimes affected and the sensitivity is low. So although they have ocular dry eye, they don't express it to the doctor when you just go through the questionnaire. So that is another issue while treating these patients. Many of them are diabetic also with peripheral neuropathies. So it is important to check ocular surface sensitivity also in these patients. Now, if you just take all the findings together, that in all parameters, glaucoma patients fared much poorer than the non-glaucoma subgroup. Tolerance to medication, almost 100% of glaucoma patients had at least one symptom, and redness and dry eye feeling was the most reported symptom in these patients. Patients exposed to glaucoma are likely to have worse ocular parameters. They had higher inflammatory response and greater loss of meibomian glands. So it is better to stick to the preservative-free medications while treating these patients. A lower amount of dry eye, we just start with HPMC or basic drops, and as it becomes worse, we add sodium hyaluronate or dextran or other components to the tear substitute, or even the autologous serum. Punctal plugs are controversial in glaucoma patients because with punctal plugs, the drop retention on the ocular surface might increase with worsening the effect of BAK if you're using drops with BAK. We find a lot of glaucoma patients having meibomian gland problems along with poorer meibom scores. So we do LipiFlow, and we have found that large number of patients' ocular inflammation improves after doing a LipiFlow. It is better to stick to other forms of treatments like SLT to reduce load of glaucoma medications, and MIGS, which will be launched soon, will be a real boon for us because that preserves ocular surface to the maximum. So thank you so much. And as a true Mumbaiker, I'm just waiting to get into VT station in the peak times.
Yeah. Thank you, Dr. Nitin. That is a very common problem in nowadays with the patients who are using the anti-glaucoma medication. So I request the next speaker, Dr. Parikh Dave, to talk on newer drug delivery systems in glaucoma.
Good morning, everybody. Good morning, Arup sir. Good morning, Dr. Pandav sir. Good morning, everybody. Good morning.
Good morning, ma'am. Good morning.
Good morning.
Good morning, ma'am. Good morning.
Good morning, Dikshit sir.
Good morning, Ragini ma'am.
Good morning, Tushar sir.
Good morning, Ragini.
Can I start? Is everything set?
Yeah.
Okay. At the outset, I'd like to thank BOA and Dr. Manisha in particular for giving me this opportunity. So my talk will be under the following heads, and we'll discuss each one by one. So my talk is on the newer drug delivery systems. What should be the ideal drug delivery system? The ideal system should have a long duration, preferably more than 6 months. It should have a 24-hour IOP lowering. The intraocular pressure lowering should be at par with the prostaglandin analog, similar to it, and with a similar adverse effect profile. The system should be bioerodible to minimize the need for invasive removal, and the installation or injection should be an in-office procedure. So let us start with the periocular inserts. One particular insert is this bimatoprost ring implant. It is a 24 to 29 millimeter ring which rests beneath the eyelid, and it has bimatoprost embedded in the silicone matrix, and it gives us a sustained release of bimatoprost up to 6 months after installation. This is how you actually put the ring inside the eye, just to show you how it is done. In a study done in this particular study, wherein a bimatoprost ring plus artificial teardrops were compared with a placebo insert with timolol, and what they found out was that the ring was in place in 88.5% of the patients at the end of 6 months. Dislodgements were there, 28 dislodgements were noted, and all were promptly noticed by the patient themselves. The side effect profiles and discontinuation rates were similar between the two groups. However, non-inferiority to timolol was not achieved. Another device is the TOD, or the Topical Ophthalmic Drug Delivery device. So this is developed by Amorphex Therapeutics. It's a flexible device which floats on the tear film, and it is concealed under the upper lid. They have completed phase 2 trials with timolol, and this has demonstrated safety, comfort, retention, efficacy for about 180 days. And this can be used for other ocular disorders as well, where chronic therapy is required. Moving on to the punctal or canalicular plugs. This particular travoprost plug is developed by Ocular Therapeutics. So it is basically travoprost encapsulated in resorbable hydrogel rod. This has to be placed in the superior or the inferior canaliculus, and it is fluorescein incorporated in order to make it easily accessible and visible. In this particular study, they used 26 plugs which were placed in 17 patients, and what they found out was that the IOP reduction was 24% on day 10, and this reduced to 15.6% on day 30 from baseline. One required removal of the plug due to epiphora as a symptom, and the retention rates were not that great. They were only 42%. Another phase 2 study, in this particular study, what they did was they compared the punctal plug plus artificial tear, which were given in the form of eye drops, versus timolol drops plus non-drug eluting plugs, and they did a 90-day follow-up. So what they found out was that, in fact, IOP lowering was better in the timolol plus no drug plugs. This was probably because of the longer drug retention in the timolol group due to the punctal occlusion. The retention rates initially were good, around 90% at the end of 60 days, but then this gradually reduced to 48% at the end of 90 days. Moving on to the anterior chamber implants. So this bimatoprost sustained release implant is now US FDA approved, and it is available under the brand name of Durista, marketed by Allergan. So this is basically based on the Novadur platform. The Novadur platform is the platform which our retina colleagues use to inject the Ozurdex implant. So this is the same platform. So this is an intracranial injection which is based on the 28 gauge applicator system. Phase 2 studies have shown that the IOP lowering of the implant is comparable to that of topical bimatoprost group, and the adverse effects documented in this study were hyperemia, foreign body sensation, eye pain, lacrimation, conjunctival hemorrhage, and punctate keratitis. So this is how this is the size of the implant. This is how small it is. This is the applicator inserter system, and this is the implant, the gonioscopic view in the inferior angle. Phase 3 multi-center studies have shown that the efficacy is comparable to timolol twice daily, and the IOP reduction is to the tune of 30% from baseline. This sustained release implant had fulfilled the non-inferiority criteria, and after this important, interesting feature which was noted was that after 3 treatments, 80% of the patients required no treatment for another 12 months. So this was thought to be because of the sustained suppression or reduction in the episcleral venous pressure. This is the iDose sustained release implant. So this is basically a titanium implant where drug elutes through a membrane cap. The insertion is similar to iStent, which is used in MIGS procedures. The anchored portion is advanced through the trabecular meshwork into the scleral tissue. Phase 2 trials are currently underway to establish non-inferiority to timolol. But when the disadvantage of this implant is when it depletes, it has to be removed and replaced. So the obvious concerns with the intracranial implants are that they are invasive. There is irritation from injection. There's difficulty with explant if complications arise. And there are obvious concerns regarding the corneal endothelium. Moving on to the subconjunctival implants. And now there are numerous subconjunctival implants of glaucoma medication which are under development. However, most have the following limitations: that they all induce a local immune response. The release is non-linear. They follow non-linear release kinetics. And our understanding of scleral permeability is less vis-a-vis the corneal permeability. And there is obviously need for operating room requirement. Moving on to the last group, that is miscellaneous. The various drug-eluting contact lenses are currently under development. There are also microdose sprays which are being developed, wherein the medication would be released as a spray, and this would improve the head positioning and it would result in less tearing. Also, you have various bioadhesive matrices which are under development, which would stay on the ocular surface for extended period of time. Another interesting study which at least I am eagerly awaiting the results of, is this intravitreal brimonidine, which is currently under study for reducing geographical atrophy area in ARMD. So as a corollary, it may also reduce the intraocular pressure as well. So it will be interesting to see the detail of the results as to how effective this is in reducing the intraocular pressure. So to conclude, I'd like to say that basics of how to instill eye drops, spending time with the patients, telling them that punctal occlusion has to be done, keeping space between two medications, etc., is still of paramount importance. The implants have the potential to dramatically improve the compliance in glaucoma patients, which is historically very, very poor. The patient's attitude for implants, unfortunately, may not always be very forthcoming, and the search for the ideal drug delivery system is definitely still on, and novel innovations have the potential to reshape glaucoma management. So with this, I'd like to conclude. Thank you so much for your patient listening.
Thank you, Dr. Parikh, for giving us a talk on the new modalities in the glaucoma management, and that is very much needed in the coming era, because looking at the compliance of the anti-glaucoma management, it will be a really boom. So thank you, Dr. Parikh. So I invite our next speaker, Dr. Shepaly Parikh, to talk on nanotechnology in glaucoma management.
Unmute your mic, Shepaly.
Yeah, it's fine.
Yeah. Share your screen. Thanks.
Yeah. So good morning, everybody. I would like to thank BOA for giving me this opportunity, and I'm going to talk on nanotechnology in glaucoma management. Now, before I go into the details regarding the, it's not changing. 1 second, it's not changing. Well, 1 second. It's not able to share it.
Shepaly, you need to use arrows instead of space bar.
Yeah, no, I'm doing that only. 1 sec. Yeah, so yeah, it's working. So before I go into the detail regarding its use in glaucoma management, just a little bit about what is nanotechnology. So nanoscience is the study of phenomena and on manipulation of material at atomic and the molecular and submolecular level, and any technology that deals with the design characteristic at this size, that is referred to as the nanotechnology. Now, the concept of nanotechnology is not new. Its history dates back to nearly 6th century BC. Recently, the pottery has been excavated in which the coating of the nanomaterial has been found, and it still retains its stability and adhesion. So nanotechnology is basically the convergence of science and engineering, and it has helped medicine to work with increased efficacy and better efficiency. So just to put into perspective, so I have just compared it with the micron. What is the difference between micron and nanometer scale? We are used to seeing RBCs under the microscope. It is we see it with the great difficulty. So when you compare the micron with the nanometer, 1 micron is equal to 1000 nanometers. So you can understand that when we deal with nanotechnology, how much smaller the size or the tiny particles we are dealing with. So what makes this nanotechnology different from macrotechnology? It is basically the difference in this particle size. Because of this minute size, the surface area of these particles, they decrease tremendously, and because of which the drug carrying capacity of these particles or of these nanoparticles, it increases drastically. And also because of the small size, it changes the physical properties. Like if you take the copper, which is when it is a macromolecule, it is a larger, it is an opaque substance. But when you convert it into the nanoparticle, then it becomes transparent. So it drastically changes the physical property. So I'm not going into detail regarding the epidemiology of glaucoma. We know it is ever-growing burden on the society, and by 2040, its projected prevalence is going to be 110 million. And the current modality of treatment at this point of time, we all know, is the topical drops. However, it has its own limitation, like reduced bioavailability. It causes tissue irritation and damage. There is a reduced shelf life. It is not able to reach at the target in time. So there comes comes the role of nanotechnology. It provides the sustained release, it improves the bioavailability. Basically, all the limitations of the current topical anti-glaucoma medication, they can be more or less overcome by this nanotechnology. This is a short video which I have kept. This you can see, these are the shiny particles which are basically the nanoparticles. They are such a small particles. It increases the surface area and also it improves the penetration into the cornea, because of which the drug availability at any site increases tremendously. Now there are different nano drug delivery systems. This is list of these drug delivery systems, and we choose this delivery system depending on the drug site, target tissue, and the route of administration. Now, a little bit about the scientific evidence that we have regarding the nanotechnology. In fact, whatever Dr. Parikh has talked, more or less everything uses this nanotechnology. So currently for this, we have this list of nano drug delivery system. And for this anti-glaucoma medication, we are using this nano drug delivery system. Then we have nano devices. Then we have intraocular pressure monitoring device. It has its role in protection, regeneration, gene therapy, and also regeneration of the trabecular meshwork. We cannot go into detail, but little bit about the glaucoma medication and a nano device I will be talking. Now, if you compare the commercially available xylitol with the latanoprost loaded liposome. Now, liposome is the drug delivery system. So here, if you see the red color graph, that is for the latanoprost loaded liposome. And when you give the first injection of this latanoprost loaded liposome, its effect is more or less at par with the commercially available xylitol. And when you give the second injection of this liposome at the end of 5th month, then the effect of this, it continues for another 6 months, and while its effect becomes better compared to the commercially available drops. Similarly, timolol, a lot of research is going on. There are different drug delivery systems, and very recently an enzyme-triggered release contact lens system was engineered for timolol delivery using the nanodiamonds. Brimonidine, we have drug delivery system inserts, which it is shown to have better IOP lowering compared to the commercially available drops. Similarly, we have combination of timolol and dorzolamide, where the drug delivery system is nanofiber patches, and its efficacy lasts for up to 3 days. Methazolamide, if you see here, red color graph, the IOP lowering efficacy of methazolamide is much better compared to the commercially available methazolamide or plain nanoparticles, or even the sodium chloride. So basically, this drug delivery system, it increases the efficacy, and the dosing is also reduced drastically. Duresta, already Dr. Parikh has discussed, it is already launched in the USA market, and in India it may be expected soon. It is a drug-eluting polymer, and in fact lasts for 3 months. And Artemis trial have shown its efficacy to be 30%. It causes 30% intraocular pressure reduction by end of 3 weeks. Similarly, we have nano drainage devices, where you can load these devices with the mitomycin antifibrotics like mitomycin C and 5-fluorouracil, and it slowly releases the 5-fluorouracil even till the end of 28th day also. And this nano drainage devices, they operate with ferrofluidic nanoparticles, and they have supramagnetic properties. Just to that how smaller the size of these nano devices are, you can compare it with the tip of the pen, and they are able to maintain the pressure between 7 to 10 millimeters of mercury. One of the prototype is ND implant, which is being developed, and it is composed of nanoporous membrane and polymeric shaft. Similarly, we have punctal plug delivery system. Dr. Parikh has already discussed. They are sustained release travoprost and latanoprost punctal plugs, which are already developed, and in the travoprost is in the market also. Similarly, we have a 24 hours IOP monitoring device like Triggerfish, which are again based on the nanotechnology. The intravitreal injection of the glial-derived neurotropic factor for the neuroprotection of retinal ganglion cell, which is being used with the microsphere. It has shown 12.6% increase in the retinal ganglion cell density in 8 months, and also increase in the cell survival. Also, it has role in gene therapy. So to conclude, the nanotechnology is definitely our future generation medicine, and it overcomes a lot of limitations of the currently available anti-glaucoma medication as it increases the bioavailability and ensures sustained target delivery. However, this is a new medicine, and like this pandemic going on, we are not much aware of what are the drawbacks or what are the side effects. So the safety concerns, especially the nanotoxicity in the form of particle, excipient, contaminant, and inflammatory toxicity needs to be addressed. Thank you. Thank you all.
Thank you, Dr. Shepaly, for updating the newer technologies for the nano delivery systems in the drugs, in the walls. It will be a great help in the glaucoma therapy. Thank you, Shepaly, ma'am. So I invite Dr. Sushma Tejwani to give her talk on trabeculectomy and its modification.
Good morning. Thanks, Dr. Nitin. And I must thank Dr. Manish, Sunil, and BOA for giving me this opportunity. So after listening to the high-tech nanotechnology talk, I'm bringing you back to the very conventional trabeculectomy technique and its various modifications. Well, so I'm going to talk about certain general principles, then surgical techniques, and how we use antifibrotics, releasable sutures, ologen, and needling in trabeculectomy. Well, different techniques have different indications, and the choice largely depends on multiple factors for choosing any surgery. So for that matter, in glaucoma, it depends on what is the target IOP for an individual, what are the previous surgeries patient has undergone, how is the risk profile, and what is the preference of the operating surgeon. In addition to definitely taking into account what is the patient's opinion about a particular surgery and what are the expectations, how do you expect the patient to come post-operatively or follow your advice post-operatively. Well, keeping in mind those things, the broad indications for trabeculectomy are usually when optic nerve function is failing and is likely to fail on maximum tolerated medical therapy. The laser treatment is not able to bring the target IOP. And this also includes patients who have poor compliance or side effect or poor accessibility or affordability to the medication and still progression of visual field. EGS has also suggested that cases who present to you with advanced glaucoma and very high IOP at presentation can be directly taken up for the surgery or trabeculectomy as well. Interestingly, trabeculectomy still remains the most popular surgery and has lots of possibilities of customization and manipulation even after the surgery. So let's go to the techniques one by one. So I'll just show a basic conventional technique of trabeculectomy. Well, here, what I'm showing you is a limbal-based conjunctival incision. I still use it for certain patients like young patients, children, where I don't want the limbal incision to get disturbed. So once you retract the flap and cauterize the episcleral vessels, then a triangular scleral flap, partial thickness flap is taken. Some people prefer to take a rectangular flap. Any triangular or rectangular does not matter much. Based on your preferences, you can choose that. This is a partial thickness flap. The important thing is that you have to maintain the same plane. This is the marking of the trabecular meshwork block that we are going to cut, and then you can use a straight 1As or MVR or a blade to make it full thickness entry. You can use a Kelly's punch to remove that trabecular meshwork block, or even the straight 1A scissors. You can hold the block and cut it across. Usually 1 to 3 millimeter is what we do. And then a full thickness peripheral iridectomy is done. You can see the pupil being pulled there. And then you have to make sure that it is a full thickness iridectomy before you close the scleral flap. Scleral flap is sutured with Tenno nylon sutures, a single suture or 3 sutures based on your preference and the amount of leak that you see. Now, limbal-based flap, I prefer to suture with a continuous purse string suture with 8O vicryl, so that there is minimum amount of knots. So these flaps are particularly very comfortable for the patient because they hardly have any irritation. Well, many a times, or rather majority of the times when we talk about glaucoma, we have to take a combined surgery. That means cataract and glaucoma surgery. So when we are operating for a patient for intraocular pressure lowering and there is a visually significant cataract is when we plan, or a patient where we are taking up for cataract surgery and patient is on multiple medications for glaucoma treatment and there is advanced glaucomatous optic neuropathy, that is where we do the combined surgery. So based on the level of desired IOP control and what is the anticipated benefit for cataract with cataract extraction in a given patient is when we decide that we would do the combined surgery. Just a couple of things that there is hardly any difference between one site or a two-site approach. So you can go ahead with whatever you prefer surgically. There are not much differences in limbal and fornix-based conjunctival flap in terms of outcome. Well, mitomycin C should be used in most of the cases when you're particularly doing a combined surgery, unless there is a contraindication for its use. So when you combine a phacoemulsification with trabeculectomy, what I simply do is take a side port and make a CCC and form the chamber with viscoelastic and then create a fornix-based conjunctival flap, like we usually do in any trabeculectomy for that matter, and raise a partial thickness scleral flap. After marking the trabecular meshwork, you can enter through the same incision if you prefer a single side and complete the phacoemulsification, insert the lens in the bag, and then complete the trabeculectomy steps like removal of a trabecular meshwork block excision by whichever method you feel comfortable with, and peripheral iridectomy, and then closure of the scleral flap as earlier. The closure of conjunctival flap is a little different here. Here I'm using interrupted suture. The important thing is that you have to anchor these sutures to the episcleral tissue at the limbus so as to avoid the retraction of the conjunctival flap. If you have to combine a trabeculectomy with a small incision cataract surgery, it is very simple. The incision that you take for a small incision, you can take it a 1 millimeter anterior so that you don't have to create an additional triangular or rectangular flap. This particular case, I'm using a Blumenthal incision, and then after completing the cataract extraction, same way, remove the trabecular meshwork block and PI, and then you can use a single suture or two sutures close to where you have done the trabecular meshwork block excision, which can work as a filtration site. The closure of the conjunctiva is same as I showed you in the previous video, or the fornix-based flap. Well, the role of anti-metabolites is very, very important. Mitomycin C has become almost a rule in most of the situations where we do trabeculectomy. The concentration can vary based on the amount of drop that you need in a particular patient. It can vary from 0.2 to 0.4, and it can be used for a duration of 2 to 5 minutes. Even post-operatively injections is something that are used by some patients. So what we usually do is that according to the Moorfield safer surgery system, the mitomycin C is applied not at a single site, rather multiple sponges are used at a wider application area so that you can get a more posteriorly directed flow and a posteriorly directed blend. There are other anti-metabolites which are used, 5-FU being the next more popular. The others like anti-VEGF, TGF, beta, monoclonal antibodies, etc. are not yet in the clinical use. There is not significant evidence yet. Well, 5-FU particularly is preferable in the post-operative phase is what I prefer. When you have a congested bleb or fibrosis, early fibrosis coming up, you can, in the clinic itself, you can give a subconjunctival injection of 0.1 ml or 50 milligram per ml. That is how it is available commercially. So you don't have to dilute. So just inject close to the bleb, and 3 to 7 injections like that can be given at weekly intervals. It can really work very well if used judiciously in the early phase of bleb congestion or fibrosis beginning. Well, another technique that we can use in trabeculectomy is a releasable suture. When you particularly want to avoid hypotony in the initial phase, but you need a relatively lower target pressure for future. When mitomycin C is contraindicated and you are anticipating hypotony in the initial phase, so when the surgical outcome is not very predictable and you need to keep a scope for adjusting the intraocular pressure post-operatively by suture release, is when these sutures come handy. You can use 1, 2, or 3 releasable suture based on amount of adjustment that you need post-operatively. However, these are not preferable in children or patients who cannot cooperate on slit lamp post-operatively. So the technique is again very simple. After you take an apical suture to close the scleral flap, you can use a partial thickness corneal tunnel here for that, keeping that end of the suture. And when you're taking a side suture, you just use 4 throws, a single knot, and use this thread's loop to tie the knot. You can release it and see whether it is releasing, and then cut the edge so that the cut edge stays in the corneal tunnel so as to avoid the windshield wiper effect. When post-operatively, you need to remove it. Again, it is very simple. You either need to cut it when you don't want to release the suture or remove it. So both I'm showing here. It's a little arm video where you can remove this, take this edge out of the corneal tunnel that you had created during surgery, and I'm using a needle. So hold the suture, and with the help of the needle, you can cut the edge so that the edge is no longer, the end is no longer available, or making it prone for the infections. Now, if you want to release it, same way, you have to remove this or take it out from the corneal tunnel that you had created. And once the suture is out, you can pull it in the downward direction. So as you pull it out, the whole suture, the knot opens and the whole suture comes out. What is important here is when you release the suture, post that, you should do a Siegel's test to make sure that there is no leak from the area. And if at all you find a micro leak, you can use a bandage contact lens. The other options for removing the sutures are laser suturolysis when you don't put a releasable suture. However, that definitely requires use of a lens and a laser, and cannot be done in all cases. The suture should be visible for you to be able to do that. So that's how releasable sutures have an advantage over laser suturolysis. Now, another important implant that is in vogue is a biodegradable collagen matrix implant called Ologen. Well, Ologen is again used like a spacer after you close the, while you're closing the scleral flap. It is used between the conjunctiva and the sclera so as to create, avoid fibrosis. So as far as the IOP lowering efficacy is concerned, it is definitely not as high as with MMC. There have been studies which have compared that when you use Ologen with MMC, so it does not improve the efficacy. However, it is being more popularly being used as to avoid that thin-walled avascular bleb that you get after MMC. I don't have much of a personal experience with Ologen, but this is what I'm talking about based on the reported literature. Now, needling is another thing where trabeculectomy, when tends to fail, it can come as a savior. But what we need to understand is it is used when the external ostium is closed due to subconjunctival fibrosis. However, the internal ostium has to be patent. It can work for as long as even 6 months later after the surgery. So in initial phase, when you have such situation that internal ostium is closed, or when you are seeing there is congestion, you can use digital massage or suturolysis, etc. But once there is organized fibrosis, these things do not help. And that is when the needling can revive the bleb. The procedure is very simple. It can be done under topical anesthesia. So what you need to use is a bent 23 gauge needle, and you can enter to a little away from the bleb and reach the external ostium where you are expecting the fibrosis. You can use the needle tip to excise or cut that or release that fibrosis around the external ostium so that you can regain the aqueous flow from the internal ostium. Once you have done enough dissection to release the fibrosis in external ostium, you need to make sure that you enter the anterior chamber through the internal ostium so that the flow is established. As you take out the needle, what you have to make sure that there is no leak from the area where the needle is exited. And if you see that, you can suture it off by a single suture. And that is how needling can be used. Usually when I do needling, I give a 5-FU injection at the adjacent site so as to avoid the further fibrosis. The possible complications with the needling can be overfiltration, hyphema, or subconjunctival hemorrhage. It can also cause hypotony. So those are the things that we need to keep in mind, but it is still a very safe and effective procedure and a low-cost procedure before you actually want to do a second trab or more interventional procedures. So just to conclude, there are lots of scopes of customization for trabeculectomy surgery. Like if you need lower IOP or based on your target IOP, you can alter the dose of mitomycin C and duration so as to have the achieved target IOP. You can use releasable sutures if you want to avoid particularly early post-op hypotony and still achieve the lower pressures long term. Digital massage, laser suturolysis or release of suture or use of 5-FU injections if the early post-op increase in IOP or bleb congestion is what you see. Ologen can be used if you're worried about very thin, fragile MMC bleb in a given patient. And there is still possibility to revive the bleb with needling, even if the pressure increases in the late post-operative phase. Well, thank you for your kind attention.
Thank you, Dr. Sushma, for the point-to-point talk. I know it's a very vast topic, but you covered it well and a very good video presentations. Thank you, Dr. Sushma.
Thank you.
Now I request Dr. Arup Chakravarti sir for his presentation, Small Pupil in Glaucoma.
Good morning, friends, and thanks a lot, Manish and the organizing team for having me here today. The first approach in managing any small pupil situation is to achieve a maximum pharmacological mydriasis. In certain situations, the pupil size is still small or suboptimal, and we need to think about alternate strategies to have a larger pupil to make the subsequent cataract surgery safer for the patient as well as for the surgeon. Now, when I peruse the program booklets and I see topics like phaco in unmodified small pupil, phaco sans OVD, phaco sans BSS, so I feel it is just phaco sans conscience. So whenever you have a pupil which is less than 3 to 4 millimeters, or in certain situations when even it is little larger, but has associated comorbidities, for example, a shallow anterior chamber, a unhealthy cornea, very hard cataract, we must resort to a small pupil strategy. And there are a plethora of possibilities, plethora of devices available for us. And personally, these are the devices which are there in my armamentarium. But what I'm going to talk to you today is to have a strategy so that we can reduce the dependence on these devices. Because a device, after all, is an additional intervention, and that can always have associated complications. It has a learning curve and it is expensive. So I'm going to discuss with you certain pearls or certain things that I always use in my practice, and use this so that I avoid using devices in most of my cases, and only as a last resort where nothing else works, I'll be using a device. So it is important for us to know what are the exact etiology of the small pupil. From 2004 onwards, and after the IFIS was published by Campbell and David Chang, so it has become a very important piece of history. So I always try to find out, am I dealing with an IFIS candidate, or is it a traditional etiology of small pupil that I'm dealing with? And we have a system where the nurses run through all the all the medications that can give rise to miosis, and then and IFIS, and those patients are segregated, and we have a separate strategy. Pupillary fatigue is something which you need to avoid, because if you're using cyclopentolet the day before the surgery, it has been shown that it reduces the pupillary dilatation by a factor of 0.73 millimeters from the situation when you have used tropicamide 1%. So if you have a pupil, if you want to dilate to 6 millimeter, and then you get a 0.73 millimeter less dilatation because I've used cyclopentolet the day before, and it has resulted in pupillary fatigue, your pupillary area is going to be reduced by 23%. So if at all you have to dilate the pupil for your workup, either the fundus workup or whatever, use tropicamide 1%. And then another thing is, as I mentioned earlier, we'd like to pick up the IFIS candidates. So in the literature, there has been a discussion that a pupil size not dilating, maximum mydriasis, less than 6.5 or 7 millimeters or 8 millimeters, you need to be very careful about those patients, because they may have intraoperative miosis. And actually, there was now so these measurements are cumbersome. You have to take an anterior segment picture, and then you may have to use a caliper preoperatively and to find out what exactly the proportions. So this particular paper has described the intuitive, the PL ratio, pupil to limbal diameter ratio. So you just look at the pupils, the patient's dilated pupil, and then if it is less than 60% by intuition, you feel it less than 60%, then you can think about the patient developing IFIS in the intraoperative period. So many a time I get pupils like that on the surgical table, and the nurses say that, doctor, this patient is allergic to tropic acid plus, so I have used only homide or the cyclopentolate. But what I tell my staff is, on the day of the surgery, it is still possible for us to use tropic acid plus drops. So this is what was the maximum dilatation with only tropicamate, without the plus, without the phenylephrine component. And when I added it, I got an adequate sized pupil, and if safe emulsification was done. This is the post-op picture. This is the day one picture. Because we are going to put topical steroids immediately after the surgery, and on the first day about 6 times a day. So the allergy factor really doesn't come into the consideration. In the bargain, you get a well-dilated pupil, and you can avoid pupillary devices and perform a safe surgery. So we use adrenaline in the infusion fluid, and half an ampoule of 1 in 1,000 preservative-free adrenaline. Some surgeons have used intracamerally in IFIS patients, though I'm not a big fan of any intracameral use. Recently, we had a product launch called Phenocan Plus from a company, Indian company. Actually, this is already available in the Western market, a product called Midren, which are the same components. So this actually was looked into and was published in a JCRS article in March 2018. And it showed that there is maximum pupillary dilatation within 30 seconds. And the mid-race is stable. Pupil doesn't come down. And you don't require really any additional pupillary dilatation devices or any additional doses intraoperatively. And the important thing is, that when they compare the decrease in the pupillary size more than 3 millimeters, in the topical group, it was seen in 20 patients, whereas in this particular group where Midrange was used, it was only in 1 patient. Now, among all the devices, I am a big fan of these iris hooks for various reasons, and these are disposable devices, very simple to use. You just need a 27 gauge needle to manipulate these iris hooks into the patient's eye. And though I have, why you prefer the iris retractors over the other ring expanders? You can use it even uveitic people where there's posterior synechia, people have become ectopic. It can give selective dilatation. For example, when I'm doing a vitrectomy and there is the reverse pupillary block, the lens iris diaphragm retropertion syndrome. So I can just use an iris hook just to gently lift up the iris from the anterior lens capsule. So the tremendous deepening of the anterior chamber, which otherwise may happen, does not occur. It can be safely used in phakic and vitrectomy's eyes. If we use ring devices in these cases where the pupil post-vitrectomy, some of these high myopic patients, when the pupil comes down and becomes large, the ring devices may dislocate and it may go into the posterior chamber. So it may be difficult, additional maneuver for you to retrieve it and reapply it or take it out, whatever. And these devices, the iris hooks, can also be used once, after the capsulotomy has been done. I'll just show you a video when there is intraoperative meiosis and you feel that you're not able to manage the nucleus or the cortex adequately without a larger pupillary dilatation. And then in certain situations, like when you have not expected a significant zonulopathy, or whenever there's a zonular dialysis, you can use the same iris hook. Though if a capsular hook is preferable, but in this kind of situation, you can definitely use an iris hook to stabilize the capsular bag. For example, then these hooks can also be used to stabilize the ring, the capsular tension segment, which has got this eyelet. You can pass it through the eyelets and stabilize. So you don't have to suture the capsular tension device intraoperatively. At the end of the surgery, it can be done. So let us see this video. Now, this was a intermission cataract and a very shallow anterior chamber. And I started off surgery. There's viscomydriasis, pupil dilated extremely well. And this patient developed IFIS intraoperatively. You'll see here pupil becoming small, surgery becoming difficult. So I decided to use an iris hook in between, intraoperatively. So one precaution here is when you apply the iris hook, and the same thing also holds true for any ring device, you make sure that the hook does not hook the capsular rhexis margin. In this particular case, I had a rhexis stair which went to the periphery. So you inject OVD between the iris and the anterior capsule, create a very friendly zone, and ensure that the iris hook only hooks around the pupillary margin and it doesn't take the rhexis margin. So this is an important tip to keep in your mind when you operate on these patients. It has potential problems, and of course, any device, anything will have potential problems if you don't handle it carefully. My other non-hook devices that I really enjoy using is the Malignant ring version 2, which can go in through a very small incision, and it gives rise to 6.25 or 7 millimeter pupil. It has a very thin profile. BHEX by Suven Bhattacharya is again one of my favorite devices. It has a very low vertical profile. I have used iris expanders from Beaver as well as from the Oasis. They're pretty good. And there has been a study. These are some of the devices. Gupta ring has just come into the market. I've used only trial. I've not been very comfortable using these devices. So which device is superior? Now, this particular study in JCRS, it compared the Malignant ring with the Visitech eye ring. And the results were very interesting. It showed that, with the Malignant ring, the pupillary cosmetic effect post-operatively was worse compared to the Visitech eye ring. And this is, again, a comparison between whether you should iris hooks or Malignant ring or phenylephrine. This is the largest study published in Eye recently, I think from the Moorfields group. And the results were, again, very interesting. It showed that the Malignant ring had maximum incidence of iris sphincter tear compared to iris hooks or by intracameral myotics. And the other complications seem to be little more, atonic pupil, corneal edema, cystoid macular edema, DM tear was more in the Malignant ring group. So this group, their take-home message was, though the complications were not high with any of these, but with Malignant ring, somehow the complication rate was higher. So friends, whenever I'm dealing with an IFIS pupil, make sure that, you follow the general surgical principles. So wound is properly constructed, hydrodissection is done in a slower manner, in a gentle manner, lower all irrigation aspiration parameters, have an appropriate OVD strategy. And if it is really a very small pupil to start with, you don't hesitate in using a mechanical expansion device. So in conclusion, you need to know what exactly is the etiology classification. Is it an IFIS candidate that you're dealing with? Pharmacologic modulation is extremely important. Use a sphincter sparing non-device option to start with, because post-operatively cosmesis will be much better, particularly if you're using a advanced technology intraocular lens. And a device use has to be considered when a patient has significant comorbidities, a hard cataract, a shallow anterior chamber, questionable zonular status, and if the pupil is very small. Thank you so much for your kind attention.
Thank you, Dr. Arup sir, for such a wonderful demonstration how to maximize your pupil during the surgery with the help of the pharmacological agents with the devices. Thank you very much, sir. It was a very good and informative presentation as usual, sir. So next, I invite Dr. S.S. Pandav, sir, to speak on the Ahmed Wall globby.
Do we have time?
Yes, sir. We have time. You can go ahead. I mean, it's an important topic.
I'll make it as short as possible. So, Ahmed glaucoma value implant, my technique. So I'll basically show you a few videos of my technique, how I do it. And this AGV is actually a valve device. You all know it, and this is used to control intraocular pressure in refractory glaucoma, where other things have failed. So that means when the drugs are not working, the laser is not working, and you've already done a couple of surgeries, at least one trap with MMC has already been done, and then you tend to switch to a glaucoma drainage device. So this is a valve device, so there are less problem with the hypertonic post-operative, and you have less complications to deal with. AGV is also used as a primary surgery in certain situations where glaucoma surgery is unlikely to fail. Something like, if you have a neovascular disease which is not well controlled, or uveitis. So I'll just straight away go to the steps. And the first and the most important step is that once you have prepared the patient for surgery, draped, and you have put the speculum to expose, then the first thing is to make a peritomy. And the way I make it, I expose the superior temporal quadrant unless for some reason it's not available. So make a small radial incision and cut the tendons capsule as well as the conjunctiva in one go at the limbus, and you just need to expose one quadrant, but it's better to be a little generous with the incision so that you don't end up stretching and manipulating tissue. So once it is done, so you can see this, the quadrant is exposed very neatly, and you can clearly see the demarcation between the anterior and the posterior part of the sclera. The posterior part of the sclera is actually a little avascular than the anterior part, and this demarcation is by the line of insertion of the muscles. So this is important to identify this, because I'll place my implant entirely in the avascular part and not in the vascular part anteriorly. That means I'll push it behind the line of insertion of the muscles. So once that is done, we are ready for the second step. And the second step is to prime the tube. So it's very important the valve AGV must be primed, because this has a membrane valve somewhere here, and initial opening pressure is quite high. It could be 50-60 millimeters of mercury pressure. So if you have not primed the valve, it's not going to open in the post-operative period, and this is going to be a primary failure. So this step is very important to establish a communication, the fluid communication through this system. And once that is done, you are ready to put this implant basically into the sclera, the pocket that you created. So I like to put the implant a little far away, at least 9 or 10 millimeters from the limbus. So that is clearly in the posterior, behind the line of insertion of the muscles. And this is a part of the sclera which is a little less vascular as well. So I use pre-placed suture, about 6 millimeters apart. That's roughly the size of the eyelets on the implant. And I use a spatulated needle on a 6 or 5 dacron suture, but you could use any suture. I prefer this needle because these needles are specifically designed for retina, retinal buckles, and basically to pass suture the sclera. So they are much safer than other needles, and for that reason, I basically use this needle. So once I have put the pre-placed suture, just insert the implant gently into the pocket. It should go very easily. Actually, you don't have to use any force. If you have to use any force, that means your dissection is not good, and then you should go back, look at the sclera pocket, the pocket that you have created, subtendinous pocket that you have created, and then if there's any problem there, sort it out before you put the implant. And once the implant is actually put into the place, you could do a little bit of cautery if required. You don't need much cautery, but if there's too much vascularization, then you can do a gentle cautery. And after that, you are ready to put the implant basically into the tube into the anterior chamber. Now, what I am here doing is I have cut the tube to the desired size, so that is about 2 millimeters in the anterior chamber, after insertion. And I have to figure out where would the tube enter. And the entry of the tube would be at the point where the sclera spur is there. So I figure out where the sclera spur would be, and I would go about a wivel length behind. So I'll go about a wivel length behind the expected point of entry, and that will give me at least 2 millimeters of tunnel, or you can go a little behind to have 3 millimeters or tunnel. So ideally you should have about 2.5 to 3 millimeters or sclera tunnel through which you would push this needle. So I'm pushing the needle intrasclerally, and when I reach that point, I'm going to turn this a little to the side and also into the anterior chamber. So I like to make a curved track actually, just to get a little more length, and also is more so that it fits in snugly. And if you put the tube straight in the anterior chamber and if it's longer, then it's more likely to have endothelial touch and also endothelial loss. Now, why I'm exiting from this tunnel, I like to make a small side cut, which you see here. Now, this makes a funnel-like opening in the beginning so that you can insert your tube easily. So the beginning of the insertion is easy. Because it's a very tight tunnel, so it takes a little effort to thread it through it, but I think you have to be gentle and persistent, and invariably it'll go into the anterior chamber. And now you can see the tube should start appearing somewhere here. So because I made a little curved tunnel, so it should be somewhere there, the tube should come here. You can see now tube is becoming visible there, and this is about the desired length, about 2 millimeters in the anterior chamber, and that is, I think, nicely. So the tube has to be away from the cornea and not touching the iris. But if it's closer to the iris, that is preferable, but it should not be away from the cornea. If the anterior chamber depth is not good enough, then one can go posteriorly into the sulcus for the sulcal placement of the tube as well. And in that case, you might do a little peephole idectomy here to facilitate the insertion. And the final step, of course, is the closures. And I like to close it with the, I always put a square patch graft. This is a full thickness square patch graft, but you can use it, you can thin it out or shave it off if you're not comfortable. But the more the support there, the less likely would be the erosion of the tube in the post-operative period. And some people nowadays recommend that if you don't want to put a square patch graft, you could make a longer tunnel with a needle. So make it like 3 millimeters or 3.5 millimeters, then maybe you need not put this patch graft there. But I like to put it in all my cases because that gives me a extra safety. Because the most important thing is to prevent erosion of the tube in this area, because if that erodes, then your implant would fail, and there would be endophthalmitis and other things. And finally, you wrap the conjunctiva and tendons capsule over the implant and over the patch graft, as I said. So it's important to bring both the layers, the conjunctiva as well as the tendons capsule together, and don't leave behind the tendons capsule, because if you leave behind the tendons capsule, it's going to scar, differently, and then it might extrude the implant. So once it is wrapped around, you can put sutures on the sides, and you can see this is nicely closed, and you have a tube of adequate length and anterior chamber. And that essentially basically completes the procedure. You could do an antibiotic drop at the end of the surgery, so I think I will skip this video. This is just to show you that the implant is possible even in a situation when there's glaucoma surgery is actually glaucoma surgery is other surgery is not possible, but because of paucity of the time, this was a complete video, so I'll skip it because we are already at the end of our session. And thank you very much for giving me this opportunity, BOA, Dr. Manish, Sunil. Thank you very much for this invitation, and all those who are listening patient. Thank you.
Thank you, Pando sir, for an excellent video presentation. So where to implant the wall, how to insert the tube, how to place a scleral graft, that will be definitely useful for the new beginner, sir. Thank you very much, sir. Over to you, Dr. Sunil, sir.
Yeah. Okay. Thank you all speakers, and thank you the chair. I think we've finished right in time. Thanks to Dr. Pandav for cutting his talk short. So I think we can close this session with the permission of the chair. Dr. Arup, we can close this session.
So we have 5 to 10 minutes. I think next session will start at 10:30. Can we have a discussion of 5 minutes, or we will end the session?
I think there's a question for Dr. Pandav.
Yes.
Sir, can you take this?
Yes.
Would you prefer your preferred site is only superior-temporal or at 12 o'clock? That's the question from Dr. Deepak Vaidya.
Superior-temporal. The implant, it goes in the superior-temporal between the two muscles, like superior rectus and lateral rectus muscle. But the tube could be directed a little bit more toward the 12 o'clock position. Because if you're putting a patch graft, sometimes the patch graft is visible if you put it too temporally. So you could have a little curved course for the tube, and the tube can come a little toward the 12 o'clock position. But the implant goes in the superior-temporal quadrant as a preferred place. But if superior-temporal quadrant is not available, then you could go to the inferior nasal or inferior-temporal. So first preference is superior-temporal, inferior nasal.